Welcome to Women We Should Know with international speaker, mindset reset mentor, author, and your host, Leslie Michaels. With audacious honesty and candor, the Women We Should Know podcast presents the wisdom and life-empowering insights of women who are the embodiments of innovation and social evolution. Please join Leslie as she shares potent conversations that will inspire your personal and professional evolutions. Welcome to Women We Should Know.
Welcome back to Women We Should Know, the podcast where we consistently bring you women of great audacity, great courage, who are breaking boundaries, shifting paradigms, and bringing us new levels of understanding that are going to impact all women across the country and around the world. These are women who do not color inside the lines. They do not get inside of boxes created by other people, and they do not sing other people's songs. These are women who are out there carving new paths. And the most brilliant thing about each one of these women is that as they carve a new path, every one of them is leaving a light on so that we can see how to follow if that feels like somewhere we want to go, we want to visit, or we want to take a long journey. Today, I have for us Patrice D'Amato. She has spent 38 years as a practicing nurse in both clinical and academic settings with a focus on adult medical, surgical, critical care, and women's health. After practicing as a women's health nurse practitioner in abortion care more than 20 years ago, she left clinical practice to teach nursing at the university level. So, Patrice is a clinical nurse with abortion experience, and she leans into information that is highly factual. And that is why I wanted to bring her here. One of the many reasons I wanted to bring her here to speak with all of you today. She is an award-winning educator and has served as a university course director for a top-ranked school of nursing. She also serves as a project director for an international health organization dedicated to providing education opportunities in developing countries. Patrice's passion for nursing started early in childhood as she saw the deep pride and satisfaction her mom and grandmother derived from the early era of professional nursing. And I think we'll get to hear a little story or two about her mom's experience. She was born in New York and now lives in Maryland. And in her free time, she volunteers as a hospice singer and teaches conversational English in Spanish-speaking countries such as Spain and Peru. She is going to bring to us today a unique difference in understanding between personal abortion stories and those told by a nurse, someone who has been in clinical practice. So I am very pleased and excited to be able to introduce her to all of you. Hi, Patrice. Thank you for being with us today.
Hi, it's great to be here.
Certainly, you have the hot button topic right now.
I do indeed. I really didn't expect for my book to come out at the exact same time as the Roe versus Wade decision, but there it was.
Well, the universe had alternate plans to yours.
Indeed.
And I like the way you call this the girlfriend's guide to abortion. What does that mean for our listeners?
Well, that was actually a disparaging term that I was told by somebody at the university level who does a lot of work in social policy at the national and international level, and a women's health person. And, you know, I had a friend give this person a rough draft of my book, and they started reading, and they said, I can't read this. It's more like, it reads like a girlfriend's guide to an abortion, not that high level, view of the issue as it stands. And my friend was a little hesitant to tell me that this person really couldn't get through the book. And I said, no, that's great. That's what I want. I want to be able to talk about this as somebody's, in very highly informed friend. Because I believe that's where a really important place for change to take place. We have what's happening in the political and social arenas, but I think that the changes, a really profound way for us to change is to start looking at this from within. It's an inside job, is what I like to say. And so in thinking about this in terms of the very real, very lived nuances of what happens to our girlfriends was a perfect way for me to go.
It's brilliant. And wow, you are certainly capable of writing one of those high level technical terms books or publications. I can see a greater need for your approach because there are so many firm believers for, firm believers against, and in between that, I see a glut of women saying, I don't understand about this. I don't understand about that. And for you to be able to present a book that is personable is profoundly helpful, I believe.
I'm really glad. I'm glad because that was my intent, was to be able to bring this down to a level. The beauty about being a nurse, I will say, Leslie, is that I can walk in the world of the white collar professional, but I also can equally put on my scrubs and be, completely embedded in the blue collar world. And that, I love that. I love that one day, somebody's seeing me, giving a lecture. And then the next day, I'm hanging out with dietary staff, and the level of trust that you can have, it's an honor, no matter where you are. If you're speaking to the janitor or you're speaking to the CEO, it's an honor to be there and to be heard. So for me, this has been the perfect career for me to be able to do that.
Well, that's wonderful. And for the record, I had no problem getting through your text.
Oh, good.
None whatsoever.
Great.
There are many things I want to discuss today. I have a very long grocery list, but I want to dive into two, what I consider highly crucial issues that I doubt the majority of people know about. I certainly didn't know about it until we spoke. So to lay a bit of a foundation for our listeners to understand why, with all the many conversations about abortion, I chose to have a conversation with you. I want to dive into two important points. And those are, first of all, what you were sharing with me about ER staff calling you for medical tutorials, and then followed up, but connective, I'm sure, is the substandard care that is available, including in blue states. And some people in blue states may be surprised to learn that that is the case.
Yeah. So what has happened? And it really started happening long ago when I first started in the field. This is not the type of specialty that, unless you have a real passion and calling, it's not a specialty that is particularly well respected or really visible. It's not like you go to a cocktail party and say, oh, I work, my specialty is abortion care. And in fact, it is a specialty, and we have we have clinical guidelines and national organizations such as NARAL, so, but it definitely has been a marginalized part of medicine and healthcare since its inception. So what often happens is that the curricula in schools, in medical school, nursing school, they don't really address abortion care. I myself, in a very ultra liberal Ivy League institution was told, no, we don't need that. We don't want that in the curriculum. And this, I was really trying just to even just limit it to students who were interested in women's health, because, 1 in every 4 women, and that's an improvement. It used to be 1 in every 3 women only 20 years ago had an abortion. And so it just seemed ludicrous to me that we weren't able to bring this into the curriculum, but it is not there. You have to learn that once you get out, or maybe if somebody really pushes to have a rotation there. But I was in charge of doing clinical placements for students, and I was told, no, it's too narrow a focus. They can't learn enough in that field. And I thought, I don't know. I am working in it, and I could tell you that they will get a really great learning experience. So we have a real problem in that staff feels pretty intimidated and unable to confidently care for patients when they present to the emergency room, which, in my current job, I do send people to the emergency room. So currently I do work as a hotline nurse for taking phone calls for women who have had the procedure, either type of medical or an in-office, what we call a surgical procedure. And there are times when they need to go to the ER. There's only so much I can do over the phone. There's only so much you can do in the if the clinic isn't open.
Yes.
So the after hours calls, patient, or if it's just like a super emergency, which does happen, usually it would be something like postpartum hemorrhage or something like that. That would be a problem. But anyway, sending people to the emergency room, I thought, oh, good, that's great. I've got them off my plate. Let me just sign off on this. And then I get a phone call more than once, quite a few times. I've gotten phone calls from the hospital staff saying, this is so-and-so, and we have this patient who says that they were a patient of yours, and we honestly don't know what to do. What should we do? And, and sometimes it's physicians, sometimes it's mid-level providers like physician assistants.
Now, let's not breeze past that statement. Sometimes it's physicians.
Yes.
I just want to make sure that is heard.
Yes. Now, when you think about it, emergency room physicians are a different breed than an OBGYN, right? And so I will say that as a nurse, in my many years of experience, ER docs tend to be a little bit nervous about obstetric issues. They just are. Yes. I remember when I was going in, as a patient to have a baby, and I was in labor, and they brought me through the ER, and I laughed because I remembered it from being a nurse. They will whip you through that ER so fast. They do not like to handle, typically, they're not real happy about handling birthing babies in the emergency department. It's not because it's such a fraught and very specific thing. I will say that I don't want to sound terribly cynical, but the number one reason for lawsuits, and most expensive ones, are obstetric in nature.
I see.
So it's a very high risk. It's a risky business working with obstetrics patients. I don't think that's the total reason. Really, I don't think that everybody is thinking lawsuit in their mind when they see, a woman dealing with pregnancy issues coming through the emergency room. More often than not, it's just that they have to have such a broad width of experience, of knowledge, that they, there's only so much they know. It would be like having a dental emergency come in. You don't really, you send that off to the specialist. So it's very similar for women's health. So that therein lies some of the issue. It's a lack of confidence. Let me
ask you this, Patrice, if I may interrupt.
Sure.
There is a different level of intimacy when you are dealing with a gynecological issue than if you are doing an open heart. I mean, both are intimate, but in a completely different way, with a completely different energy and sensibility about it. And do you feel like that plays in?
Oh yeah, absolutely. Absolutely. Yeah, it's really funny how comfortable we are talking about internal organs like the
Mm-hmm.
heart uh, in a, cocktail party or business setting, but really talking about, a gynecologic exam, even
Yeah,
just, a routine one. Um, it's so
I can.
laden.
Everyone has heard someone talk at the cocktail party about their heart incident, but you don't hear someone talking at a cocktail party about having an ovarian cyst.
No, and let alone talking about something like having an abortion or
Yes,
even just surviving, even just experiencing a miscarriage,
yes,
which is the medical term is a spontaneous abortion.
that's right.
So we just need to be clear that one is elective, one is spontaneous, but they are all abortion.
Hmm.
But yeah, you're right. It's so sad to me that we marginalize those kinds of conversations, and that people are so incredibly uncomfortable with it. And
And
my goal is
particularly
to
with women,
normalize it.
because I will say that I have in public heard men talk about their prostate, but but women, it's still that goes all the way back to the story, whether you believe it's true or mythology. It goes all the way back to Eve. That entire topic of a significant part of a woman's life is still taboo, is still private, is still a little bit shameful for some.
Absolutely, absolutely. And so, I think we're dealing with a lot of shifting in the ethos right now. And what I love seeing is that there are quite a number of medical students who are, we talked about this, really seriously considering where they're going to medical school, where they're going to practice, because they are up in arms that they're not getting the information on being
Mm-hmm.
able to take care of patients in this type of specialty. And it's a disgrace,
Mm-hmm.
and
Mm-hmm.
they've had it. So I
Mm-hmm.
think we're getting a whole new generation of young professionals who are not going to be putting up with this. They're going to be making some demands in the curriculum and or in clinical practice to bring this to the forefront, because they feel unprepared and they feel it's wrong. And it is wrong. They're right.
I recall from an earlier conversation that you said universities are suffering because there are a large number of students who are refusing to go to universities in conservative areas or conservative universities because they do not support this moratorium on abortions and even abortion knowledge. And you made a very good point, which is that is not going, the impact is not going to stop at the university level. The financial impact on those cities and states cumulatively is going to be significant if they don't change their perspective somewhat.
Yeah. And I don't know that it's a large number, but it is a significant. I'm hearing a lot of vocalization in those groups about that,
Mm-hmm.
and that comes back to right. That comes back to brain drain in
Mm-hmm.
certain regions of the country,
Mm-hmm.
and we know that not too many physicians. The shortages we have for physicians and nurses and other health professionals, really any professionals, is that if they can't practice to their fullest extent, if they can't have a lifestyle that's meaningful, you're going to have severe brain drain. And I
Mm-hmm.
will say that I do currently take care of patients in 5 different states, in various regions in the country. And it's really scary for patients when I tell them, in the heart of, wherever they are. The other week it was like Mississippi, and they didn't want to go to the hospital. They didn't feel that they were going to get good care, and I couldn't vouch for that either, especially when I get phone calls from people saying we don't even know where to begin with this. So
Mm-hmm.
it's a real concern.
Right. And I suspect that clinical health implications are even more widespread than just that topic or that issue.
Oh, yeah. Oh, for sure. But this one in particular is really hard and unique because most women will say to me, or it's the question unsaid to me is, do I have to tell them why that I had an abortion?
Mhm.
And I've gotten that in the bluest of blue states as well.
Mhm.
Do I have to tell the ER that I had an abortion? Do I have to tell my doctor that I had an
Mhm.
abortion? This is
Mhm.
one of the most common questions that I
Mhm.
encounter.
And how do you counsel those women?
You know, the ideal thing, and I do say to people, well, it would be ideal if you could tell your provider, particularly your own doctor,
Mhm.
about your gynecologic history because it really can make your care better, you know.
Mhm.
But that said, you don't have to tell them. They're not
Mhm.
necessarily going to know that you had an abortion.
Mhm.
And if you're really super concerned about your safety and getting decent, halfway decent care, you can say, well, I think I had a miscarriage. But
Mhm.
isn't that sad? Isn't that sad
It's
that we have to
it's
teach people that?
it's punishing women for just being is what I
Right.
call that. Punishing women for just being. I have many more things that I want to talk about. I can already tell that we're going to do a part two. So, listeners, when we get to the end of this, you just flip forward to the next episode and we'll keep talking about this. But while we're still here in this early part of our conversation, I would love to hear about your mom and your grandma and their impact on you.
Okay. Well, that I do outline in the book, and it was a later
Yes.
thing that came to me. I thought, geez, why didn't I ever talk about where I came from? This book is really a love letter to nurses. That's what it
Mhm.
really is.
Mhm.
And the fact that I chose to write about abortion was deliberate, I think, because I think that it's a topic that, will capture people's attention about who we are and what we do and why we do what we do.
Mhm.
Um, my grandmother was one of the first nursing students. She was in the first cohort of nursing students in her small town hospital school of nursing in central Pennsylvania back in oh probably the early 1930s,
Mhm.
yeah, actually maybe late 20s. She had to leave. She never finished nursing school because
Oh.
her mother died. She was one of 13 children and she had to go back to the
Oh.
farm. Yeah.
Wow.
So, yeah, she had to go back to the farm. Her father was a school teacher, but had a farm. And so she had to go back and raise the rest of the kids.
Mhm.
Um,
Mhm.
but she loved nursing. And she was, you can imagine the pride of being a woman in that time period
The first
and being
one.
oh, yeah, the first nursing school in
Yes.
that region.
That's an
Um,
accomplishment.
yeah, that she didn't get to complete. But even through all the way through, my mother's stories as well, it's really not something you could do if you were responsible for children or
Mhm.
responsible for a husband.
Mhm.
Once you got married, for sure, you couldn't continue in nursing school
Mhm.
or continue your education. So my grandmother,
Yes,
um,
this was back before women really, truly before women had the right to be anything
oh, yeah, I don't think you could even own
independent.
property, right?
Well, it was 1973 before we could have our own credit card.
Oh, yeah. So she went back later on. She did nursing and she lived in a very rural area, but she took care of people in their homes. She worked for a doctor's office.
Hmm.
And so, of course, that instilled into my mother. My mother was one of four girls and the only one who didn't get pregnant right out of high school. So the rest of them, they couldn't do those things because they became wives at 18.
Yes,
Um,
society at that time had no way to support them.
No, no. And I mean, now we're talking, this was the 1950s, 40s and 50s
Hmm.
for them. And again,
Hmm.
this was a rural community. It wasn't, a really sophisticated place. But my mom, got herself down to the big city and So I went to nursing school, which at that time was a diploma program. Um, and she became an RN, and she was ecstatic about that. She didn't get to practice very long because she did marry right after nursing school, got pregnant shortly after that, and wasn't allowed to work once again. It wasn't, I shouldn't say, she was allowed to work. It's just that it was impossible. The only thing that you could do was private duty. Now you might wonder, well, how did they staff the hospitals? Well, back
That's the
then,
question I'm ready to ask.
well, the hospitals were staffed by nursing students. So it was really like an indentured
Not a
servant.
superior level of care, no offense to the
No,
students.
no, not at all. It was indentured servitude all the way up through
Right.
the 70s,
Well,
unless you went
again,
to a baccalaureate school.
another abuse of women. I'm so quick to spot those.
Yes. Oh, yeah, indeed. So the hospitals were staffed by students who, of course, most of them being young women, were going to get married and not, actually work in the field. So, yeah, I mean, my mom thought it was great. She had full, responsibilities, for a whole ward of patients. She was only a student.
So there's this never ending cycle of, number one, income into the nursing schools. Number two, inexpensive to free labor. But because they're going to have to retire quickly, it's a never ending supply.
Yes, indeed. Indeed.
How
And,
interesting. I did not know this. This is interesting
well,
information.
and then there was, the joke about the MRS degree. I know I'm dating
Oh
myself, but,
gosh, yes.
yeah, a lot of women, young women, it was a great, it was an entry into meeting physicians and
Yes.
marrying a doctor. It's
Mm-hmm.
like a different world. I can't imagine your young listeners right now saying, what planet has this woman just landed from?
And yet, I love for my young listeners, and we do have young listeners, and we also have young guests sometimes. Often we have everyone, all demographics, all cultures. I love for my young listeners to hear this and to understand that while it may look like we've been sitting on our laurels doing nothing for all this years, because certainly they do not have the rights they deserve. So it's reasonable that they would think we did not do our part, that they can have a point of reference to see just how much has changed. And it wasn't without fights.
And it's recent. You and I are sitting here. I'm 59 years old. I was born in 1963, and I'm not that old. So yeah, the changes are dramatic. I just had a great discussion.
I'm not that old. I was born in 1955. I'm 1967, but the changes I've seen and that I've been a part of helping to forward have been significant.
Oh yeah. It's, well, and if you would compare it to, I have a child who's 30, where we hardly had even home computers were a new thing. So even in that 30-year span, I think that young people today do realize how quickly things change, in terms of what we take for granted today, even having a cell phone.
Certainly in technology.
Oh
So,
yeah.
but your mom got to continue to work, just not at a hospital.
No, well, she worked at a hospital, then she got married, had babies, and stayed home with us until my youngest sister was in high school. Then she did go back to work, became an occupational health nurse, and absolutely loved it. So she did return to the field after her kids were well enough raised. But my mom was the person who inspired me unwittingly to work in abortion care for a good portion of my career. And I do talk about that a lot in the book because, I always start it with a quote, and, it's that "be careful what you say to your kids" thing.
That's right.
Because she was not happy with my choice of going to work in an abortion clinic at all.
Mm.
But she was the woman
Nursing
who
was
said,
fine, but not that particular area.
yeah, there were plenty of respectable things to do. And I had done respectable things. But, my mom.
The implication being that abortion is not.
Yes, it was very untidy. And she was having trouble telling her
Untidy.
friends.
Oh, gosh. Yes, that's a word from our youth.
Able to brag to her friends to tell them what I was doing. It was just, you don't say that in the suburban neighborhoods.
Right.
Well, where's Patty working these days? No. And yet she was the person who inspired all this through her stories at the kitchen table about
Mhm.
what it was like when she was in the hospital working as a nursing
Mhm.
student. And, the one particularly poignant story that I talk about is, having
Mhm.
a patient who was raped and
Yes.
they didn't know who the father was, but they would at the time of birth, given the child's, skin tones, and how devastating and unfair that was.
Mhm.
And she was deeply shaken and felt that it was horribly wrong to judge, and that the woman was forced to carry this pregnancy that was probably the result of a rape. So her stories about that and her outrage, we sat at that table during the 60s. My mom was a young suburban mom. She wasn't she wasn't out in the world as so many women were,
Mhm.
really fighting the good fight. We
Mhm.
knew about women's lib, but we saw it on the news and we saw women burning bras, and we thought that was really weird and, again, untidy.
Untidy.
Ew.
Well, here's a little fact for you. Here's a little tidbit for you. Women did burn bras, but it was actually, that stunt was started by a reporter who was looking for an explosive article.
Wow.
And the women didn't realize that this reporter had started, and that's how that got going.
Wow,
There's
it's
a little
just
bit of history trivia from somebody who was one of those hippie kids out there doing all that stuff.
I love it. It's just like reality TV today, right?
Yes.
There's a plant. There's a plant.
There's a plant
to make a big story.
That's right.
And you don't find that out till after the fact. So already your first impression is, oh, it was crazy.
What
right?
a weird thing to do. Yes.
Right.
I want to talk about what fetus worship is. I want to talk about the issue of mailing abortion pills. I want to talk about this terrorist activity in New Jersey. So what I'm going to do is thank you for coming here today. And we are going to record a part 2 for all of you out there. Now you have a preview to what we're going to be discussing. Some of those very hard, tough topics around this issue. But Patrice, thank you for coming and having this conversation with me.
It's been my pleasure.
And for all of you out there listening, I'm going to put Patrice's information, the title of her book, the book link, her contact info, anything she is willing to give me to share with you, I will put in her program notes. So thank you for joining us again. I trust that you learned something meaningful, something that changed the way you see your life, women's lives, and came to a different level of understanding about this very difficult issue. So as you go through the rest of your day, please remember you are stronger and wiser than you know.